Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. A Phase 3 trial of Seladelpar in primary biliary cholangitis. Background. Effective treatments for patients with primary biliary cholangitis are limited. Seladelpar, a peroxisome proliferator activated receptor delta agonist, has potential benefits. Methods. In this Phase 3, 12-month, double-blind, placebo-controlled trial, we randomly assigned, in a 2-to-1 ratio, patients who had had an inadequate response to or who had a history of unacceptable side effects with ursodeoxycholic acid to receive oral Seladelpar at a dose of 10 mg daily or placebo. The primary endpoint was a biochemical response, which was defined as an alkaline phosphatase level less than 1.67 times the upper limit of the normal range, with a decrease of 15% or more from baseline, and a normal total bilirubin level at month 12. Key secondary endpoints were normalization of the alkaline phosphatase level at month 12 and a change in the score on the pruritus numerical rating scale, range 0, no itch, to 10, worst itch imaginable, from baseline to month 6 among patients with a baseline score of at least 4, indicating moderate to severe pruritus. Results. Of the 193 patients who underwent randomization and treatment, 93.8% received ursodeoxycholic acid as standard of care background therapy. A greater percentage of the patients in the Seladelpar group than in the placebo group had a biochemical response, 61.7% versus 20.0%, difference, 41.7 percentage points, 95% confidence interval, c. 27.7 to 53.4, p less than 0.001. Normalization of the alkaline phosphatase level also occurred in a greater percentage of patients who received Seladelpar than of those who received placebo, 25.0% versus 0%, difference, 25.0 percentage points, 95% c. 18.3 to 33.2, p less than 0.001. Seladelpar resulted in a greater reduction in the score on the pruritus numerical rating scale than placebo, least squares mean change from baseline, minus 3.2 versus minus 1.7, least squares mean difference, minus 1.5, 95% c, minus 2.5 to minus 0.5, p equals 0.005. Adverse events were reported in 86.7% of the patients in the Seladelpar group and in 84.6% in the placebo group, and serious adverse events in 7.0% and 6.2%, respectively. Conclusions. In this trial involving patients with primary biliary cholangitis, the percentage of patients who had a biochemical response and alkaline phosphatase normalization was significantly greater with Seladelpar than with placebo. Seladelpar also significantly reduced pruritus among patients who had moderate to severe pruritus at baseline. The incidence and severity of adverse events were similar in the two groups. Efficacy and safety of Elafibranor in primary biliary cholangitis. Background. Primary biliary cholangitis is a rare, chronic cholestatic liver disease characterized by the destruction of interlobular bile ducts, leading to cholestasis and liver fibrosis. Whether Elafibranor, an oral, dual peroxisome proliferator activated receptor, PPAR, alpha and delta agonist, may have benefit as a treatment for primary biliary cholangitis is unknown. Methods. In this multinational, Phase 3, double-blind, placebo-controlled trial, we randomly assigned, in a 2-to-1 ratio, patients with primary biliary cholangitis who had had an inadequate response to or unacceptable side effects with ursodeoxycholic acid to receive once-daily Elafibranor, at a dose of 80 mg, or placebo. The primary endpoint was a biochemical response, defined as an alkaline phosphatase level of less than 1.67 times the upper limit of the normal range, with a reduction of greater than or equal to 15% from baseline, and normal total bilirubin levels, at week 52. Key secondary endpoints were normalization of the alkaline phosphatase level at week 52 and a change in pruritus intensity from baseline through week 52 and through week 24, as measured on the Worst Itch Numeric Rating Scale, YNRS. Scores range from 0, no itch, to 10, worst itch imaginable. Results: a total of 161 patients underwent randomization. A biochemical response, the primary endpoint, was observed in 51% of the patients, 55 of 108, who received Elafibranor, and in 4%, 2 of 53, who received placebo, for a difference of 47 percentage points, 95% confidence interval, c. 32 to 57, p less than 0.001. The alkaline phosphatase level normalized in 15% of the patients in the Elafibranor group, and in none of the patients in the placebo group at week 52, difference, 15 percentage points, 95% C, 6 to 23, p equals 0.002. Among patients who had moderate to severe pruritus, 44 patients in the Elafibranor group and 22 in the placebo group, the least squares mean change from baseline through week 52 on the YNRS did not differ significantly between the groups, -1.93 versus -1.15, difference, -0.78, 95% C, -1.99 to 0.42, p equals 0.20. Adverse events that occurred more frequently with Elafibranor than with placebo included abdominal pain, diarrhea, nausea, and vomiting. Conclusions: treatment with Elafibranor resulted in significantly greater improvements in relevant biochemical indicators of cholestasis than placebo. Cognition and memory after COVID-19 in a large community sample. Background: cognitive symptoms after coronavirus disease 2019, COVID-19, the disease caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, are well recognized. Whether objectively measurable cognitive deficits exist and how long they persist are unclear. Methods: we invited 800,000 adults in a study in England to complete an online assessment of cognitive function. We estimated a global cognitive score across 8 tasks. We hypothesized that participants with persistent symptoms, lasting greater than or equal to 12 weeks, after infection onset would have objectively measurable global cognitive deficits, and that impairments in executive functioning and memory would be observed in such participants, especially in those who reported recent poor memory or difficulty thinking or concentrating, brain fog. Results: of the 141,583 participants who started the online cognitive assessment, 112,964 completed it. In a multiple regression analysis, participants who had recovered from COVID-19 and whom symptoms had resolved in less than 4 weeks or at least 12 weeks had similar small deficits in global cognition as compared with those in the no COVID-19 group, who had not been infected with SARS-CoV-2 or had unconfirmed infection, -0.23 SD, 95% confidence interval C, -0.33 to -0.13, and -0.24 SD, 95% C, -0.36 to -0.12, respectively. Larger deficits as compared with the no COVID-19 group were seen in participants with unresolved persistent symptoms, -0.42 SD, 95% C, -0.53 to -0.31. Larger deficits were seen in participants who had SARS-CoV-2 infection during periods in which the original virus or the B.1.1.7 variant was predominant than in those infected with later variants, for example, -0.17 SD for the B.1.1.7 variant versus the B.1.1.529 variant, 95% C, -0.20 to -0.13, and in participants who had been hospitalized than in those who had not been hospitalized, for example, intensive care unit admission, -0.35 SD, 95% C, -0.49 to -0.20. Results of the analyses were similar to those of propensity score matching analyses. In a comparison of the group that had unresolved persistent symptoms with the no COVID-19 group, memory, reasoning, and executive function tasks were associated with the largest deficits, -0.33 to -0.20 st. These tasks correlated weakly with recent symptoms, including poor memory and brain fog. No adverse events were reported. Conclusions. Participants with resolved persistent symptoms after COVID-19 had objectively measured cognitive function similar to that in participants with shorter duration symptoms, although short-duration COVID-19 was still associated with small cognitive deficits after recovery. Longer-term persistence of cognitive deficits and any clinical implications remain uncertain. Simple versus radical hysterectomy in women with low-risk cervical cancer. Background. Retrospective data suggests that the incidence of parametrial infiltration is low in patients with early-stage low-risk cervical cancer, which raises questions regarding the need for radical hysterectomy in these patients. However, data from large, randomized trials comparing outcomes of radical and simple hysterectomy are lacking. Methods. We conducted a multi-center, randomized, non-inferiority trial comparing radical hysterectomy with simple hysterectomy, including lymph node assessment in patients with low-risk cervical cancer, lesions of less than or equal to 2 cm with limited stromal invasion. The primary outcome was cancer recurrence in the pelvic area, pelvic recurrence, at 3 years. The pre-specified non-inferiority margin for the between-group difference in pelvic recurrence at 3 years was 4 percentage points. Results. Among 700 patients who underwent randomization, 350 in each group, the majority had tumors that were stage IB1 according to the 2009 International Federation of Gynecology and Obstetrics (FIGO) criteria, 91.7%, that had squamous cell histologic features, 61.7%, and that were grade 1 or 2, 59.3%. With a median follow-up time of 4.5 years, the incidence of pelvic recurrence at 3 years was 2.17% in the radical hysterectomy group and 2.52% in the simple hysterectomy group, an absolute difference of 0.35 percentage points, 90% confidence interval, -1.62 to 2.32. Results were similar in A per protocol analysis. The incidence of urinary incontinence was lower in the simple hysterectomy group than in the radical hysterectomy group within 4 weeks after surgery, 2.4% versus 5.5%, p equals 0.048, and beyond 4 weeks, 4.7% versus 11.0%, p equals 0.003. The incidence of urinary retention in the simple hysterectomy group was also lower than that in the radical hysterectomy group within 4 weeks after surgery, 0.6% versus 11.0%, p less than 0.001, and beyond 4 weeks, 0.6% versus 9.9%, p less than 0.001. Conclusions. In patients with low-risk cervical cancer, simple hysterectomy was not inferior to radical hysterectomy with respect to the 3-year incidence of pelvic recurrence, and was associated with a lower risk of urinary incontinence or retention. Next article from Journal of American Medical Association: Long-Term Outcomes of Medical Management versus Bariatric Surgery in Type 2 Diabetes. Importance: randomized clinical trials of bariatric surgery have been limited in size, type of surgical procedure, and follow-up duration. Objective: to determine long-term glycemic control and safety of bariatric surgery compared with medical/lifestyle management of type 2 diabetes. Design, setting, and participants. T2D, Alliance of Randomized Trials of Medicine versus Metabolic Surgery in Type 2 Diabetes, is a pooled analysis from 4 U.S. single-center randomized trials conducted between May 2007 and August 2013, with observational follow-up through July 2022. Intervention participants were originally randomized to undergo either medical/lifestyle management or one of the following 3 bariatric surgical procedures: Roux-en-Y gastric bypass, sleeve gastrectomy, or adjustable gastric banding. Main outcome measures. The primary outcome was change in hemoglobin A1c, HbA1c, from baseline to 7 years for all participants. Data are reported for up to 12 years. Results: a total of 262 of 305 eligible participants, 86%, enrolled in long-term follow-up for this pooled analysis. The mean SD, age of participants was 49.9, 8.3 years, mean SD, Body mass index was 36.4, 3.5, 68.3% were women, 31% were black, and 67.2% were white. During follow-up, 25% of participants randomized to undergo medical/lifestyle management underwent bariatric surgery. The median follow-up was 11 years. At 7 years, the 1C decreased by 0.2%, 95% C, minus 0.5% to 0.2%, from a baseline of 8.2%, in the medical/lifestyle group and by 1.6%, 95% C, minus 1.8% to minus 1.3%, from a baseline of 8.7%, in the bariatric surgery group. The between-group difference was minus 1.4%, 95% C, minus 1.8% to minus 1.0%, p less than 0.001, at 7 years and minus 1.1%, 95% C, minus 1.7% to minus 0.5%, p equals 0.002, at 12 years. Fewer anti-diabetes medications were used in the bariatric surgery group. Diabetes remission was greater after bariatric surgery, 6.2% in the medical/lifestyle group versus 18.2% in the bariatric surgery group, p equals 0.02, at 7 years and at 12 years, 0.0% in the medical/lifestyle group versus 12.7% in the bariatric surgery group, p less than 0.001. There were 4 deaths, 2.2%, 2 in each group, and no differences in major cardiovascular adverse events. Anemia, fractures, and gastrointestinal adverse events were more common after bariatric surgery. Conclusion and relevance: after 7 to 12 years of follow-up, individuals originally randomized to undergo bariatric surgery compared with medical/lifestyle intervention had superior glycemic control with less diabetes medication use and higher rates of diabetes remission. Changes in healthcare workers' economic outcomes following Medicaid expansion. Importance: the extent to which changes in health sector finances impact economic outcomes among healthcare workers, especially lower-income workers, is not well known. Objective: to assess the association between state adoption of the Affordable Care Act's Medicaid expansion, which led to substantial improvements in healthcare organization finances, and healthcare workers' annual incomes and benefits, and whether these associations varied across low and high-wage occupations. Design, setting, and participants' differences analysis to assess differential changes in healthcare workers' economic outcomes before and after Medicaid expansion among workers in 30 states that expanded Medicaid relative to workers in 16 states that did not, by examining U.S. individuals aged 18 through 65 years employed in the healthcare industry survey in the 2010 to 2019 American Community Surveys. Exposure time: varying state-level adoption of Medicaid expansion. Main outcomes and measures: primary outcome was annual earned income, secondary outcomes included receipt of employer-sponsored health insurance, Medicaid, and supplemental nutrition assistance program benefits. Results: the sample included 1,322,263 healthcare workers from 2010 to 2019. Healthcare workers in expansion states were similar to those in non-expansion states in age, sex, and educational attainment, but those in expansion states were less likely to identify as non-Hispanic Black. Medicaid expansion was associated with a 2.16% increase in annual incomes, 95% C, 0.66% to 3.65%, p equals 0.005. This effect was driven by significant increases in annual incomes among the top 2 highest earning quintiles, beta coefficient, 2.91% to 3.72%, which includes registered nurses, physicians, and executives. Healthcare workers in lower earning quintiles did not experience any significant changes. Medicaid expansion was associated with a 3.15 percentage point increase in the likelihood that a healthcare worker received Medicaid benefits, 95% C, 2.46 to 3.84, p less than 0.001, with the largest increases among the 2 lowest earning quintiles, which includes health aides, orderlies, and sanitation workers. There were significant decreases in employer-sponsored health insurance and increases in SNAP following Medicaid expansion. Conclusion and relevance: Medicaid expansion was associated with increases in compensation for healthcare workers, but only among the highest earners. These findings suggest that improvements in healthcare sector finances may increase economic inequality among healthcare workers, with implications for worker health and well-being. Next article from Annals of Internal Medicine. A risk profile using simple hematologic parameters to assess benefits from Baricitinib in patients hospitalized with COVID-19, a post-hoc analysis of the adaptive COVID-19 treatment trial 2. Background: the at-risk profile, which was developed from A.I.O, adaptive COVID-19 treatment trial 1, demonstrated that hospitalized patients with COVID-19 in the high-risk quartile, characterized by low absolute lymphocyte count, ALC, high absolute neutrophil count, ANC, and low platelet count at baseline, benefited most from treatment with the antiviral remdesivir. It is unknown which patient characteristics are associated with benefit from treatment with the immunomodulator Baricitinib. Objective: to apply the at-risk profile to the A2 cohort to investigate potential Baricitinib-related treatment effects by risk quartile. Design: post-hoc analysis of A2, a randomized, double-blind, placebo-controlled trial. ClinicalTrials.gov, NCT 044015779 setting. 67 trial sites in 8 countries. Participants: adults hospitalized with COVID-19, N equals 999, 85% U.S. participants. Intervention: Baricitinib plus remdesivir versus placebo plus remdesivir. Measurements: mortality, progression to invasive mechanical ventilation, IMV, or death, and recovery, all within 28 days, ALC, ANC and platelet count trajectories. Results: in the high-risk quartile, Baricitinib plus remdesivir was associated with reduced risk for death, hazard ratio, HR, 0.38, 95% C, 0.16 to 0.86, P equals 0.020, decreased progression to IMV or death, HR, 0.57, C, 0.35 to 0.93, P equals 0.024, and improved recovery rate, HR, 1.53, C, 1.16 to 2.02, P equals 0.002, compared with placebo plus remdesivir. After 5 days, participants receiving Baricitinib plus remdesivir had significantly larger increases in ALC and significantly larger decreases in ANC compared with control participants, with the largest effects observed in the high-risk quartile. Limitation: secondary analysis of data collected before circulation of current SARS-CoV-2 variants. Conclusion: the at-risk profile identifies a subgroup of hospitalized patients who benefit most from Baricitinib treatment and captures a patient phenotype of treatment response to an immunomodulator and an antiviral. Changes in ALC and ANC trajectory suggest a mechanism whereby an immunomodulator limits severe COVID-19. Next article from Nature Medicine. Impact of extreme weather events on healthcare utilization and mortality in the United States. Climate change is intensifying extreme weather events. Yet a systematic analysis of post-disaster healthcare utilization and outcomes for severe weather and climate disasters, as tracked by the U.S. government, is lacking. Following exposure to 42 U.S. billion-dollar weather disasters, severe storm, flood/severe storm, tropical cyclone and winter storm, between 2011 and 2016, we used a difference in differences (DID) approach to quantify changes in the rates of emergency department (ED) visits, non-elective hospitalizations and mortality between fee-for-service Medicare beneficiaries in affected compared to matched control counties in post-disaster weeks 1 to 2 and 3 to 6. Overall, disasters were associated with higher rates of ED utilization in affected counties in post-disaster week 1, DID of 1.22%, 95% C, 0.20% to 2.25%, P less than 0.020 through week 2. Non-elective hospitalizations were unchanged. Mortality was higher in affected counties in week 1, DID of 1.40%, 95% C, 0.08% to 2.74%, P equals 0.037, and persisted for 6 weeks. Counties with the greatest loss and damage experienced greater increases in ED and mortality rates compared to all affected counties. Thus, billion-dollar weather disasters are associated with excess ED visits and mortality in Medicare beneficiaries. Tracking these outcomes is important for adaptation that protects patients and communities, health system resilience and policy. Next article from British Medical Journal. Ultra-processed food exposure and adverse health outcomes, umbrella review of epidemiological meta-analyses. Objective to evaluate the existing meta-analytic evidence of associations between exposure to ultra-processed foods, as defined by the NOVA food classification system, and adverse health outcomes. Results: the search identified 45 unique pooled analyses, including 13 dose-response associations and 32 non-dose response associations, N equals 9,888,373. Overall, direct associations were found between exposure to ultra-processed foods and 72.71% health parameters spanning mortality, cancer, and mental, respiratory, cardiovascular, gastrointestinal, and metabolic health outcomes. Based on the pre-specified evidence classification criteria, convincing evidence, Class I, supported direct associations between greater ultra-processed food exposure and higher risks of incident cardiovascular disease-related mortality, risk ratio 1.50, 95% confidence interval 1.37 to 1.63, grade equals very low, and type 2 diabetes, dose-response risk ratio 1.12, 1.11 to 1.13, moderate, as well as higher risks of prevalent anxiety outcomes, odds ratio 1.48, 1.37 to 1.59, low, and combined common mental disorder outcomes, odds ratio 1.53, 1.43 to 1.63, low. Highly suggestive. Class 2, evidence indicated that greater exposure to ultra-processed foods was directly associated with higher risks of incident all-cause mortality, risk ratio 1.21, 1.15 to 1.27, low. Heart disease-related mortality, hazard ratio 1.66, 1.51 to 1.84, low. Type 2 diabetes, odds ratio 1.40, 1.23 to 1.59, very low. And depressive outcomes, hazard ratio 1.22, 1.16 to 1.28, low, together with higher risks of prevalent adverse sleep-related outcomes, odds ratio 1.41, 1.24 to 1.61. Low. Wheezing, risk ratio 1.40, 1.27 to 1.55, low. And obesity, odds ratio 1.55, 1.36 to 1.77, low. Of the remaining 34 pooled analyses, 21 were graded as suggestive or weak strength, Class 3-4, and 13 were graded as no evidence, Class V. Overall, using the grade framework, 22 pooled analyses were rated as low quality, with 19 rated as very low quality and 4 rated as moderate quality. Conclusions: greater exposure to ultra-processed food was associated with a higher risk of adverse health outcomes, especially cardiometabolic, common mental disorder, and mortality outcomes. These findings provide a rationale to develop and evaluate the effectiveness of using population-based and public health measures to target and reduce dietary exposure to ultra-processed foods for improved human health. They also inform and provide support for urgent mechanistic research. Added benefit and revenues of oncology drugs approved by the European Medicines Agency between 1995 and 2020, retrospective cohort study. Objectives: to evaluate the added benefit and revenues of oncology drugs, explore their association, and investigate potential discrepancies between added benefit and revenues across different approval pathways of the European Medicines Agency, EMA. Design retrospective cohort study. Setting oncology drugs and their indications approved by the EMA between 1995 and 2020. Main outcome measures: added benefit was evaluated using ratings published by 7 organizations, health technology assessment agencies from the United States, France, Germany, and Italy, 2 medical oncology societies, and a drug bulletin. All retrieved ratings were recategorized using a 4-point ranking scale to indicate negative or non-quantifiable, minor, substantial, or major added benefit. Revenue data were extracted from publicly available financial reports and compared with published estimates of research and development (R&D) costs. Finally, the association between added benefit and revenue was evaluated. All analyses were performed within the overall study cohort and within subgroups based on the EMA approval pathway, standard marketing authorization, conditional marketing authorization, and authorization under exceptional circumstances. Results: 131 oncology drugs with 166 indications were evaluated for their added benefit by at least one organization within the required timeframe, yielding a total of 458 added benefit ratings. 189, 41%, were negative or non-quantifiable. The median time to offset the median R&D costs, $684 million, £535 million, €602 million, adjusted to 2020 values, was 3 years, 50 of 55, 91%. Drugs recovered these costs within 8 years. Drugs with higher added benefit ratings generally had greater revenues. Negative or non-quantifiable added benefit ratings were more frequent for conditional marketing authorizations and authorizations under exceptional circumstances than for standard marketing authorizations. Relative risk 1.53, 95% confidence interval 1.23 to 1.89. Conditional marketing authorizations generated lower revenues and took longer to offset R&D costs than standard marketing authorizations, 4 years compared with 3 years. Conclusions: while revenues seem to align with added benefit, most oncology drugs recover R&D costs within a few years despite providing little added benefit. This is particularly true for drugs approved through conditional marketing authorizations, which inherently appear to lack comprehensive evidence. Policymakers should evaluate whether current regulatory and reimbursement incentives effectively promote development of the most effective drugs for patients with the greatest needs. Next article from Lancet. Endovascular thrombectomy plus medical care versus medical care alone for large ischemic stroke, 1-year outcomes of the SELE. Background: multiple randomized trials have shown efficacy and safety of endovascular thrombectomy in patients with large ischemic stroke. The aim of this study was to evaluate long-term, at 1 year, evidence of benefit of thrombectomy for these patients. Methods: SELECT-2 was a Phase 3, open-label, international, randomized controlled trial with blinded endpoint assessment, conducted at 31 hospitals in the USA, Canada, Spain, Switzerland, Australia, and New Zealand. Patients aged 18 to 85 years with ischemic stroke due to proximal occlusion of the internal carotid artery or of the first segment of the middle cerebral artery, showing large ischemic core on non-contrast CT. Alberta Stroke Program early computed tomographic score of 3 to 5, range 0 to 10, with lower values indicating larger infarctions, or measuring 50 milliliters or more on CT perfusion and MRI, were randomly assigned, within 24 hours of ischemic stroke onset, to thrombectomy plus medical care or to medical care alone. The primary outcome for this analysis was the ordinal modified Rankin scale, range 0 to 6, with higher scores indicating greater disability, at 1-year follow-up in an intention-to-treat population. The trial is registered at clinicaltrials.gov, NCT 03876457, and is completed. Findings: the trial was terminated early for efficacy at the 90-day follow-up after 352 patients had been randomly assigned, 178 to thrombectomy and 174 to medical care only, between October 11, 2019 and September 9, 2022. Thrombectomy significantly improved the 1-year modified Rankin scale score distribution versus medical care alone. Wilcoxon Mann-Whitney probability of superiority 0 middle.59, 95% C 0 middle.53 to 0 middle.64, P equals 0 middle.0019, generalized odds ratio 1 middle.43, 95% C 1 middle.14 to 1 middle.78. At the 1-year follow-up, 77.45% of 170 patients receiving thrombectomy had died, compared with 83.52% of 159 patients receiving medical care only. 1-year mortality relative risk 0 middle.89, 95% C 0 middle.71 to 1 middle.11. Interpretation: in patients with ischemic stroke due to a proximal occlusion and large core, Thrombectomy plus medical care provided a significant functional outcome benefit compared with medical care alone at 1-year follow-up. Next article from Journal of Clinical Oncology. Clinical validation of human papillomavirus circulating tumor DNA for early detection of residual disease after chemoradiation in cervical cancer. Purpose: most cervical cancers are caused by human papillomavirus, HPV, and HPV circulating tumor DNA, CNA, may identify patients at highest risk of relapse. Our pilot study using digital polymerase chain reaction, dPCR, showed that detectable HPV CNA at the end of chemoradiation, CRT, is associated with inferior progression-free survival, PFS, and that a next-generation sequencing approach, HPV-seq, may outperform dPCR. We aim to prospectively validate HPV-CNA as a tool for early detection of residual disease. Methods: this prospective, multicenter validation study accrued patients with stage IB/IVA cervical cancer treated with CRT between 2017 and 2022. Participants underwent phlebotomy at baseline, end of CRT, 4 to 6 weeks post-CRT, and 3 months post-CRT for HPV-CNA levels. Plasma HPV genotype-specific DNA levels were quantified using both dPCR and HPV-seq. The primary endpoint was 2-year PFS. Results: with a median follow-up of 2.2, range 0.5 to 5.5 years, there were 24 PFS events among the 70 patients with HPV plus cervical cancer. Patients with detectable HPV-CNA on dPCR at the end of CRT, 4 to 6 weeks post-CRT, and 3 months post-CRT had significantly worse 2-year PFS compared with those with undetectable HPV-CNA, 77% v 51%, p equals 0.03, 82% v 15%, p less than 0.001, and 82% v 24%, p less than 0.001, respectively. The median lead time to recurrence was 5.9 months. HPV-seq showed similar results as dPCR. On multivariable analyses, detectable HPV-CNA on dPCR and HPV-seq remained independently associated with inferior PFS. Conclusion: persistent HPV-CNA after CRT is independently associated with inferior PFS. HPV-CNA testing can identify, as early as at the end of CRT, patients at high risk of recurrence for future treatment intensification trial. Next article from Clinical Gastroenterology. Hepatocellular carcinoma surveillance patterns and outcomes in patients with cirrhosis. Background and aims. Hepatocellular carcinoma, HCC, surveillance is associated with improved early detection and reduced mortality, although practice patterns and effectiveness vary in clinical practice. We aim to characterize HCC surveillance patterns in a large, diverse cohort of patients with HCC. Methods: we conducted a retrospective cohort study of patients diagnosed with HCC between January 2008 and December 2022 at 2 large U.S. health systems. We recorded imaging receipt in the year before HCC diagnosis, ultrasound plus alpha-fetoprotein, AFP, ultrasound alone, multiphasic contrast-enhanced computed tomography, CT/magnetic resonance imaging, MRI, and no liver imaging. We used multivariable logistic and Cox regression analysis to compare early tumor detection, curative treatment receipt, and overall survival between surveillance strategies. Results: among 2028 patients with HCC, 46.7% Barcelona Clinic liver cancer stage A, 703, 34.7%, had ultrasound plus AFP, 293, 14.5%, had ultrasound alone, 326, 16.1%, had multiphasic CT/MRI, and 706, 34.8%, had no imaging in the year before HCC diagnosis. Over the study period, proportions without imaging were stable, whereas use of CT/MRI increased. Compared with no imaging, CT/MRI and ultrasound plus AFP, but not ultrasound alone, were associated with early-stage HCC detection and curative treatment. Compared with ultrasound alone, CT/MRI, and ultrasound plus AFP were associated with increased early-stage detection. Conclusions: HCC surveillance patterns vary in clinical practice and are associated with differing clinical outcomes. While awaiting data to determine if CT or MRI surveillance can be performed in a cost-effective manner in selected patients, AFP has a complementary role to ultrasound-based surveillance, supporting its adoption in practice guidelines. Anti-Mullerian hormone, a marker of ovarian reserve, is protective against presence and severity of NASH in premenopausal women. Background and aims: Anti-Mullerian hormone, AMH, is a marker of ovarian reserve with emerging data linking lower levels to some metabolic and inflammatory diseases in women. Whether AMH levels influence non-alcoholic fatty liver disease, NAFLD, is unknown. Methods: leveraging the NASH Clinical Research Network, we determined the association of AMH levels within 6 months of liver biopsy with presence and severity of histologic measures of NAFLD in premenopausal women. Outcomes included presence of non-alcoholic steatohepatitis, NASH, presence and severity of fibrosis, and NAFLD activity score and its components. Logistic and ordinal logistic regression models were adjusted for age, race/ethnicity, homeostatic model assessment for insulin resistance, body mass index, dyslipidemia, polycystic ovary syndrome, estrogen-progestin use, and menstrual cyclicity. Results: median cohort age was 35 years, 73% were white and 24% Hispanic. 33% had diabetes, 81% had obesity, and 95% had dyslipidemia. On biopsy, 71% had NASH, 68% had any fibrosis, and 15% had advanced fibrosis. On adjusted analysis, N equals 205, higher AMH quartiles were inversely associated with NAFLD histology, including prevalent NASH, adjusted odds ratio, AOR, 0.64, 95% confidence interval, C, 0.41 to 1.00, NAFLD activity score greater than or equal to 5, AOR, 0.52, 95% C, 0.35 to 0.77, Mallory-Hyland, AOR, 0.54, 95% C, 0.35 to 0.82, and higher fibrosis stage, AOR, 0.70, 95% C, 0.51 to 0.98. The protective effects of AMH were more pronounced among women without polycystic ovary syndrome, N equals 164, including lower odds of NASH, AOR, 0.53, 95% C, 0.32 to 0.90, and any NASH fibrosis, AOR, 0.54, 95% C, 0.32 to 0.93. Conclusions: AMH may reflect a unique biomarker of NASH in premenopausal women, and findings suggest a novel link between reproductive aging and histologic severity of NAFLD in women. Next article from Clinical Infectious Diseases. Moving beyond mortality, development and application of a desirability of outcome ranking, DOOR, endpoint for hospital-acquired bacterial pneumonia and ventilator-associated bacterial pneumonia. Background: hospital-acquired and ventilator-associated bacterial pneumonia, HAP/VAPE, are frequently caused by multidrug-resistant organisms. Patient-centered endpoints in clinical trials are needed to develop new antibiotics for HAP/VAPE. Desirability of outcome ranking, DOOR, is a paradigm for the design, analysis, and interpretation of clinical trials based on a patient-centered, benefit-risk evaluation. Methods: a multidisciplinary committee created in infectious diseases DOOR endpoint customized for HAP/VAPE, incorporating infectious complications, serious adverse events, and mortality. We applied this to 2 previously completed, large randomized controlled trials for HAP/VAPE. Zephyr compared vancomycin to linezolid and Vital compared linezolid to didazolid. For each trial, we evaluated the DOOR distribution and probability, including DOOR component and partial credit analyses. We also applied DOOR in subgroup analyses. Results: in both trials, the HAP/VAPE DOOR demonstrated similar overall clinical outcomes between treatment groups. In Zephyr, the probability that a participant treated with linezolid would have a more desirable outcome than a participant treated with vancomycin was 50.2%, 95% confidence interval, c. 45.1% minus 55.3%. In Vital, the probability that a participant treated with tadizolid would have a more desirable outcome than a participant treated with linezolid was 48.7%, 95% c. 44.8% to 52.6%. The DOOR component analysis revealed that participants treated with tadizolid had a less desirable outcome than those treated with linezolid when considering clinical response alone. However, participants with decreased renal function had improved overall outcomes with tadizolid. Conclusions. The HAP/VAPE DOOR provided more granular information about clinical outcomes than is typically presented in clinical trials. HAP/VAPE trials would benefit from prospectively using DOOR. Next article from Journal of Clinical Rheumatology. Evaluating provider perceptions of telehealth utility in outpatient rheumatology telehealth encounters. Objective. This study aims to explore the factors associated with rheumatology providers' perceptions of telehealth utility in real-world telehealth encounters. Methods. From September 14, 2020 to January 31, 2021, 6 providers at an academic medical center rated their telehealth visits according to perceived utility in making treatment decisions using the following telehealth utility score: TUS, 1 equals very low utility to 5 equals very high utility. Modified Poisson regression models were used to assess the association between 2 scores and encounter diagnoses, disease activity measures, and immunomodulatory therapy changes during the encounter. Results. A total of 481 telehealth encounters were examined, of which 191, 39.7%, were rated as low telehealth utility, TUS 1 to 3, and 290, 60.3%, were rated as high telehealth utility, TUS 4 to 5. Encounters with a diagnosis of inflammatory arthritis were significantly less likely to be rated as high telehealth utility. Adjusted relative risk, R, 0.8061, P equals 0.004, especially in those with a concurrent non-inflammatory musculoskeletal diagnosis, R, 0.54, P equals 0.006. Other factors significantly associated with low telehealth utility included higher disease activity according to current and prior RAPID-3 scores, R, 0.87 and R, 0.89 respectively, P less than 0.001, and provider global scores, R, 0.83, P less than 0.001, as well as an increase in immunomodulatory therapy, R, 0.70, P equals 0.015. Conclusions. Provider perceptions of telehealth utility in real-world encounters are significantly associated with patient diagnoses, current and prior disease activity, and the need for changes in immunomodulatory therapy. These findings inform efforts to optimize the appropriate utilization of telehealth in rheumatology. Next article from Arthritis and Rheumatology. Kidney outcomes and preservation of kidney function with obinutuzumab in patients with lupus nephritis, a post-hoc analysis of the Nobility trial. Objective. To determine whether adding obinutuzumab to standard of care lupus nephritis, LANE, therapy could improve the likelihood of long-term preservation of kidney function and do so with less glucocorticoids. Methods. Post-hoc analyses of the Phase 2 Nobility trial were performed. Time to unfavorable kidney outcome, a composite of treatment failure, doubling of serum creatinine or death, LANE flare, first 30% and 40% declines in estimated glomerular filtration rate, EGFR, from baseline, and chronic EGFR slope during the trial were compared between patients with active LANE who were randomized to take obinutuzumab, N equals 63, or placebo, N equals 62, in combination with mycophenolate mofetil and glucocorticoids. The number of patients who achieved complete renal response, CRR, on 7.5 mg or less per day of prednisone was also determined. Results. Obinutuzumab reduced the risk of developing the composite kidney outcome by 60%, LANE flare by 57%, and first EGFR decline of 30% or 40% by 80% and 91%, respectively. Patients receiving obinutuzumab had a significantly slower decline in EFR than patients receiving placebo, with an annualized EFR slope advantage of 4.1 milliliters per minute/1.73 square meters/year, 95% confidence interval 0.14 to 8.08. Overall, 38% of patients receiving obinutuzumab compared with 16% of patients receiving placebo achieved CRR at week 76 while receiving 7.5 mg or less per day of prednisone, p less than 0.01. At week 104, the difference did not achieve significance, 38% versus 22%, p equals 0.06. Conclusion. Post hoc analyses of nobility demonstrated that compared with standard of care therapy, obinutuzumab treatment resulted in superior preservation of kidney function and prevention of lane flares. More patients achieved CRR at week 76 with less glucocorticoid use in the obinutuzumab group. Next article from Circulation. Major facilitator superfamily domain containing 5 inhibition reduces lipoprotein uptake and calcification in valvular heart disease. Background. High circulating levels of LPA, lipoprotein A, increase the risk of atherosclerosis and calcific aortic valve disease, affecting millions of patients worldwide. Although atherosclerosis is commonly treated with low-density lipoprotein targeting therapies, these do not reduce LPA or risk of calcific aortic valve disease, which has no available drug therapies. Targeting LPA production and catabolism may provide therapeutic benefit, but little is known about LPA cellular uptake. Methods. Here, unbiased ligand receptor capture mass spectrometry was used to identify MFSD5, major facilitator superfamily domain containing 5, as a novel receptor/cofactor involved in LPA uptake. Results. Reducing MFSD5 expression by a computationally identified small molecule or small interfering RNA suppressed LPA uptake and calcification in primary human valvular endothelial and interstitial cells. MFSD5 variants were associated with aortic stenosis, p equals 0.027 after multiple hypothesis testing, with evidence suggestive of an interaction with plasma LPA levels. Conclusions. MFSD5 knockdown suppressing human valvular cell LPA uptake and calcification, along with meta-analysis of MFSD5 variants associating with aortic stenosis, supports further preclinical assessment of MFSD5 in cardiovascular diseases, the leading cause of death worldwide. American College of Cardiology. Plasma ferritin levels and incident HF in older adults. Study questions. What is the association between plasma ferritin in older adults and incident heart failure, HF, HF phenotypes, and cardiac structure and function measures? Methods. This was a report from the ERIC, Atherosclerosis Risk in Communities, study, an ongoing longitudinal cohort study that enrolled 15,792 community-dwelling adults between the ages of 45 to 64 years from 1987 to 1989 at 4 U.S. sites. This analysis included 3,472 patients with no history of HF or anemia with available plasma ferritin and covariate measurements from ERIC Visit 5, 2011 to 2013. Associations between plasma ferritin level, incident HF, HF phenotype, HF with preserved ejection fraction, FEF, HF with reduced ejection fraction, FREF, or unknown, measures of cardiac structure and function, and the composite of incident HF and cardiovascular, CV, death were assessed. Results. The median age was 74 years, interquartile range, 71 to 78, 56% were women, and 14% reported Black race. Lower ferritin levels were more likely to be found in women, reported white race, lower body mass index, higher systolic blood pressure, reported aspirin use, and in those less likely to report current alcohol use. Lower plasma ferritin levels were associated with lower red blood cell indexes. A total of 293 incident HF events occurred over a follow-up period of 7.2 years with an incidence rate of 12.6 per 1,000 person-years, 95% confidence interval, c. 11.3 to 14.2. Of the incident HF events, 131 were FREF, 131 FEF, and 31 with unknown left ventricular ejection fraction, LVEF. A 50% lower plasma ferritin level was associated with a higher risk for incident HF overall, hazard ratio, HR, 1.20, 95% confidence interval, C, 1.08 to 1.34, and a higher risk for incident FEF, HR, 1.28, 95% C, 1.09 to 1.50, P equals 0.002, both after adjustment for demographics and clinical risk factors. This same association was not found with the FREF, HR, 1.16, 95% C, 0.99 to 1.36, P equals 0.07. These associations were not modified after analysis by various models including demographics, clinical risk factors, or potential confounders. Lower ferritin levels were associated with worse diastolic function by multiple measures and higher LV filling pressure but were not associated with measures of LV size or mass or measures of LV systolic function. A nonlinear relationship between plasma ferritin level and HF risk was not observed. Ferritin levels were not associated with risk for CV death, all-cause death, or the composite of incident HF and CV death. Conclusions. In older adults without a history of HF or anemia, this observational study showed an association between lower plasma ferritin levels and A. From Journals of the American College of Cardiology. Clinical presentation, classification, and outcomes of cardiogenic shock in children. Background. Despite growing cardiogenic shock, CS, research in adults, the epidemiology, clinical features, and outcomes of children with CS are lacking. Objectives. This study sought to describe the epidemiology, clinical presentation, hospital course, risk factors, and outcomes of CS among children hospitalized for acute decompensated heart failure, ADHF. Methods. We examined consecutive ADHF hospitalizations, less than 21 years of age, from a large single-center retrospective cohort. Patients with CS at presentation were analyzed and risk factors for CS and for the primary outcome of in-hospital mortality were identified. A modified Society for Cardiovascular Angiography and Intervention shock classification was created and patients were staged accordingly. Results. A total of 803 hospitalizations for ADHF were identified in 591 unique patients, median age 7.6 years. CS occurred in 207, 26%, hospitalizations. ADHF hospitalizations with CS were characterized by worse systolic function, P equals 0.040, higher B-type natriuretic peptide concentration, P equals 0.032, and more frequent early severe renal, P equals 0.023, and liver, P less than 0.001, injury than those without CS. Children presenting in CS received mechanical ventilation, 87% versus 26%, and mechanical circulatory support, 45% versus 16%, more frequently, both P less than 0.001. Analyzing only the most recent ADHF hospitalization, children with CS were at increased risk of in-hospital mortality compared with children without CS, 28% versus 11%, or 1.91, 95% C, 1.05 to 3.45, P equals 0.033. Each higher CS stage was associated with greater inpatient mortality, or 2.40 to 8.90, all P less than 0.001. Conclusions. CS occurs in 26% of pediatric hospitalizations for ADHF and is independently associated with hospital mortality. A modified Society for Cardiovascular Angiography and Interventions classification for CS severity showed robust association with increasing mortality. Next article from Journal of Clinical Endocrinology and Metabolism. At any level of adiposity, relatively elevated leptin concentrations are associated with decreased insulin sensitivity. Context. The impact of obesity on glucose homeostasis has high interindividual variability, which may be partially explained by different adipokin concentrations. Leptin regulates energy balance and metabolism, and although its plasma levels are proportional to fat mass, they vary significantly across individuals with the same level of adiposity. Objective: we tested whether glucose homeostasis differs in subjects with similar degrees of adiposity but different leptin levels. Methods: we analyzed 1,290 healthy adults from the relationship between insulin sensitivity and cardiovascular disease study cohort, 30 to 60 years, male/female, 577,713, body mass index, BMI, 25 plus or minus 3 kg/m2, characterized for body composition and metabolic variables with a 75-gram oral glucose tolerance test, euglycemic hyperinsulinemic clamp, beta cell function, and lipidomics. Results: individuals were divided into relatively high and low leptin, RHL and RLL, if they were above or below the sex-specific leptin fat mass % regression. Despite similar glucose tolerance, RHL showed markedly higher fasting and oral glucose tolerance test insulin concentration, plus 30% and plus 29%, respectively, p less than 0.0001, and secretion, plus 17% and plus 11%, respectively, p less than 0.0001. Regardless of BMI, RHL individuals had lower whole body, minus 17 to 23%, p less than 0.0001, and adipose tissue insulin sensitivity, minus 24%, p less than 0.0001, compared with RLL. Notably, lean RHL individuals showed similar insulin sensitivity and beta cell function to RLL individuals with overweight/obesity. Conclusion: subjects with leptin levels that are inappropriately elevated for their fat mass show whole body/adipose tissue insulin resistance and hyperinsulinemia, regardless of BMI. Sex hormones, the stool microbiome, and subclinical atherosclerosis in women with and without HIV context. Cardioprotective roles of endogenous estrogens may be particularly important in women with HIV, who have reduced estrogen exposure and elevated cardiovascular disease risk. The gut microbiome metabolically interacts with sex hormones, but little is known regarding possible impact on cardiovascular risk. Objective: to analyze potential interplay of sex hormones and gut microbiome and cardiovascular risk. Methods: among 197 postmenopausal women in the Women's Interagency HIV study, we measured 15 sex hormones in serum and assessed the gut microbiome in stool. Presence of carotid artery plaque was determined, B-mode ultrasound, in a subset, n equals 134. We examined associations of I. Sex hormones and stool microbiome, 2. Sex hormones and plaque, and 3. Sex hormone-related stool microbiota and plaque, adjusting for potential confounders. Results: participant median age was 58 years and the majority were living with HIV, 81%. Sex hormones, estrogens, androgens, and adrenal precursors, were associated with stool microbiome diversity and specific species, similarly in women with and without HIV. Estrogens were associated with higher diversity, higher abundance of species from allostipes, Collinsella, Erysipelotrichia, and Clostridia, and higher abundance of microbial beta-glucuronidase and aryl sulfatase orthologs, which are involved in hormone metabolism. Several hormones were associated with lower odds of carotid artery plaque, including dihydrotestosterone, 3-alpha-diol-17G, estradiol, and estrone. Exploratory mediation analysis suggested that estrone-related species, particularly from Collinsella, may mediate the protective association of estrone with plaque. Conclusion: serum sex hormones are significant predictors of stool microbiome diversity and composition. The gut microbiome may play a role in estrogen-related cardiovascular protection. Next article from Neurology. Association between beta-amyloid accumulation and incident dementia in individuals 80 years or older without dementia. Background and objectives. While the highest prevalence of dementia occurs in individuals older than 80 years, most imaging studies focused on younger populations. The rates of beta-amyloid, A-beta, accumulation and the effect of Alzheimer's disease AD pathology on progression to dementia in this age group remain unexplored. In this study, We examine the relationship between changes in A-beta deposition over time and incident dementia in non-demented individuals followed during a period of 11 years. Methods. We examined 94 participants, age 85.9 plus 2.8 years, who had up to 5 measurements of Pittsburgh Compound B, petabyte PET and clinical evaluations from 2009 to 2020. All 94 participants had 2 petabytes PET scans, 76 participants had 3 petabytes PET scans, 18 participants had 4 petabytes PET scans, and 10 participants had 5 petabytes PET scans. The rates of A-beta deposition were compared with 120 non-demented individuals younger than 80 years, 69.3 plus or minus 5.4 years, from the Australian Imaging, Biomarker, and Lifestyle (AIBL) study who had 3 or more annual petabyte PET assessments. Results. By 2020, 49% of the participants developed dementia and 63% were deceased. There was a gradual increase in A-beta deposition in all participants whether they were considered A-beta positive or negative at baseline. In a Cox model controlled for age, sex, education level, AP4 allele, baseline mini-mental state examination, and mortality, short-term change in A-beta deposition was not significantly associated with incident dementia, HR 2.19, 0.41 to 11.73. However, baseline A-beta burden, cortical thickness, and white matter lesions volume were the predictors of incident dementia. A-beta accumulation was faster, p equals 0.01, in the older cohort, 5.6%/year, when compared with ABLE, 4.1%/year. In addition, baseline A-beta deposition was a predictor of short-term change, mean time 1.88 years. Discussion. There was an accelerated A-beta accumulation in cognitively normal individuals older than 80 years. Baseline A-beta deposition was a determinant of incident dementia and short-term change in A-beta deposition, suggesting that an active A-beta pathologic process was present when these participants were cognitively normal. Consequently, age may not be a limiting factor for the use of the emergent anti-A-beta therapies. MRI versus CT for baseline imaging evaluation in acute large artery ischemic stroke, a sub-analysis of the SWIFT DIRECT trial. Background and objectives. Whether MRI or CT is preferable for the evaluation of patients with suspected stroke remains a matter of debate, given that the imaging modality acquired at baseline may be a relevant determinant of workflow delays and outcomes with it, in patients with stroke undergoing acute reperfusion therapies. Methods. In this post-hoc analysis of the SWIFT DIRECT trial that investigated non-inferiority of thrombectomy alone versus 4 thrombolysis, IVT, plus thrombectomy in patients with an acute ischemic anterior circulation large vessel occlusive stroke eligible to receive IVT within 4.5 hours after last seen well, we tested for a potential interaction between baseline imaging modality, MRI/MR angiography, MRA, versus CT/CT angiography, CTA, and the effect of acute treatment, thrombectomy versus IVT plus thrombectomy, on clinical and safety outcomes and procedural metrics, primary analysis. Moreover, we examined the association between baseline imaging modality and these outcomes using regression models adjusted for age, sex, baseline NIH stroke scale, NICE, occlusion location, and Alberta Stroke Program early CT score aspects, secondary analysis. Endpoints included workflow times, the modified Rankin scale, misses, score at 90 days, the rate of successful reperfusion, the odds for early neurologic deterioration within 24 hours, and the risk of symptomatic intracranial hemorrhage. The imaging modality acquired was chosen at the discretion of the treating physicians and commonly reflects center-specific standard procedures. Results. 405 of 408 patients enrolled in the SWIFT DIRECT trial were included in this sub-study. 200, 49.4%, patients underwent MRI/MRA, and 205, 50.6%, underwent CT/CTA. Patients with MRI/MRA had lower NICE scores, 16, interquartile range, IQR, 12 to 20, versus 18, IQR 14-20, p equals 0.012, and lower aspects, 8, IQR 6-9, versus 8, IQR 7-9, p equals 0.021, compared with those with CT/CTA. In terms of the primary analysis, we found no evidence for an interaction between baseline imaging modality and the effect of IVT plus thrombectomy versus thrombectomy alone. Regarding the secondary analysis, MRI/MRA acquisition was associated with workflow delays of approximately 20 minutes, higher odds of functional independence at 90 days, adjusted odds ratio, AOR, 1.65, 95% C 1.07 to 2.56, and similar mortality rates, AOR 0.73, 95% C 0.36 to 1.47, compared with CT/CTA. Discussion. This post-hoc analysis does not suggest treatment effect heterogeneity of IVT plus thrombectomy versus thrombectomy alone in large artery stroke patients with different imaging modalities. There was no evidence that functional outcome at 90 days was less favorable following MRI/MRA at baseline compared with CT/CTA, despite significant workflow delays. Next article from the American Journal of Respiratory and Critical Care Medicine. Elexacaftor/tezacaftor/ivacaftor treatment and depression-related events. Rationale: Elexacaftor/tezacaftor/ivacaftor, ELX/TEZ/IVA, has been shown to be safe and efficacious in people with cystic fibrosis, PWCF, aged 2 years and older with at least one F508del CFTR allele or more. After U.S. approval in 2019, reports emerged of depression-related adverse events in PWCF treated with ELX/TEZ/IVA. Objectives: to review available evidence on depression-related events in PWCF treated with ELX/TEZ/IVA in the context of background epidemiology in PWCF. Methods: safety data from 14 ELX/TEZ/IVA clinical trials and 10 trials of CF transmembrane conductance regulator, CFTR, modulators in which placebo was administered, along with data from CF registries in the United States and Germany and cumulative post-marketing adverse event data from 61,499 PWCF who initiated ELX/TEZ/IVA after initial approval in the United States, October 2019, through October 2022, were reviewed and used to calculate exposure-adjusted rates of depression-related adverse events and prevalence of depression. In addition, a scientific literature review was conducted to identify ELX/TEZ/IVA publications reporting depression-related events or changes in depressive symptoms after treatment initiation. Measurements and main results. In clinical trials, the exposure-adjusted rate of any depression-related adverse event was 3.32 100ths person years, pi, in the pooled ELX/TEZ/IVA group, and equals 1,711, and 3.24 100ths pi in the pooled placebo group, and equals 1,369. The exposure-adjusted rates of suicidal ideation and suicide attempt were also similar between the pooled ELX/TEZ/IVA group and pooled placebo group, ideation, 0.23 100ths pi versus 0.28 100ths pi, attempt, 0.08 over 100 pi versus 0.14 100ths pi. In the post-marketing setting, the exposure-adjusted reporting rates of depression-related events were low in context of the background prevalence in PWCF, all depression-related events, 1.29/pi, suicidal ideation, 0.12 100ths pi, and suicide attempt, 0.05 over 100 pi. Assessments of individual case reports were confounded by pre-existing mental health conditions, intercurrent psychosocial stressors, including coronavirus disease, COVID-19, lockdowns, and the heterogeneous and fluctuating nature of depression. Conclusions: our review of data from clinical trials, post-marketing reports, an ongoing registry-based ELX/TEZ/IVA post-authorization safety study, and peer-reviewed literature suggests that depression symptoms and depression-related events reported in PWCF treated with ELX/TEZ/IVA are generally consistent with background epidemiology of these events in the CF population and do not suggest a causal relationship with ELX/TEZ/IVA treatment. Next article from Clinical Gastroenterology and Hepatology. Alpha-1 antitrypsin augmentation, and the liver phenotype of adults with alpha-1 antitrypsin deficiency, genotype Pi*ZZ background and aims. Alpha-1 antitrypsin, AAT, is a major protease inhibitor produced by hepatocytes. The most relevant mutation giving rise to a deficiency, AATD, the Pi*Z variant, causes harmful AT protein accumulation in the liver, shortage of AT in the systemic circulation, and thereby predisposes to liver and lung injury. Although intravenous AT augmentation constitutes an established treatment of AT-associated lung disease, its impact on the liver is unknown. Methods. Liver-related parameters were assessed in a multinational cohort of 760 adults with severe AT, Pi*ZZ genotype, and available liver phenotyping, of whom 344 received augmentation therapy and 416 did not. Liver fibrosis was evaluated non-invasively via the serum test AST to platelet ratio index and via transient elastography-based liver stiffness measurement. Histologic parameters were compared in 15 Pi*ZZ adults with and 35 without augmentation. Results. Compared with non-augmented subjects, augmented Pi*ZZ individuals displayed lower serum liver enzyme levels, AST 71% versus 75% upper limit of normal, p less than 0.001, bilirubin 49% versus 58% upper limit of normal, p equals 0.019, and lower surrogate markers of fibrosis, AST to platelet ratio index 0.34 versus 0.38, p less than 0.001, liver stiffness measurement 6.5 versus 7.2 kilopascals, p equals 0.005. Among biopsied participants, augmented individuals had less pronounced liver fibrosis and less inflammatory foci, but no differences in AT accumulation were noted. Conclusions. The first evaluation of AT augmentation on the Pi*ZZ related liver disease indicates liver safety of a widely used treatment for AT-associated lung disease. Prospective studies are needed to confirm the beneficial effects and to demonstrate the potential efficacy of exogenous AT in patients with Pi*ZZ associated liver disease. Hepatocellular carcinoma diagnosis and management in 2021, a National Veterans Affairs Quality Improvement Project. Background and aims. The coronavirus disease 2019 pandemic profoundly disrupted preventative health care services, including cancer screening. As the largest provider of cirrhosis care in the United States, the Department of Veterans Affairs, VA, National Gastroenterology and Hepatology Program aimed to assess factors associated with hepatocellular carcinoma, HCC, stage at diagnosis, treatment, and survival. Methods. Veterans with a new diagnosis of HCC in 2021 were identified from electronic health records, N equals 2,306. Structured medical record extraction was performed by expert reviewers in a 10% random subsample of veterans with new HCC diagnoses. Factors associated with stage at diagnosis, receipt of treatment, and survival were assessed using multivariable models. Results. Among 199 patients with confirmed HCC, the average age was 71 years and most, 72%, had underlying cirrhosis. More than half, 54%, were at an early stage, T1 or T2, at diagnosis. Less advanced liver disease, number of imaging tests adequate for HCC screening, HCC diagnosis in the VA, and receipt of VA primary care were associated significantly with early stage diagnosis. HCC-directed treatments were administered to 145, 73%, patients after a median of 37 days, interquartile range, 19 to 54D, from diagnosis, including 70, 35%, patients who received potentially curative treatments. Factors associated with potentially curative versus no treatments included HCC screening, early stage at diagnosis, and better performance status. Having fewer comorbidities and better performance status were associated significantly with non-curative versus no treatment. Early stage diagnosis, diagnosis in the VA system, and receipt of curative treatment were associated significantly with survival. Conclusions. These results highlight the importance of HCC screening and engagement in care for HCC diagnosis, treatment, and survival, while demonstrating the feasibility of developing a national quality improvement agenda for HCC screening, diagnosis, and treatment. Next article is from Clinical and Translational Gastroenterology. Differences in mucosal permeability among patients with ulcerative colitis classified based on the colonic location and disease activity. Background: factors affecting mucosal permeability, MP, in ulcerative colitis, UC, are largely unknown. We aim to investigate the difference in MP among patients with UC classified according to the colonic locations and to evaluate the correlations between local MP and endoscopic or histological activity of UC. Methods: the transepithelial electrical resistance, TER, which is inversely proportional to permeability, of tissue samples from the mucosa of the ascending colon, descending colon, and rectum of patients with UC in healthy individuals, high, was measured by using the Ussing chamber. Tears were compared between patients with UC and high, and evaluated according to colonic locations and disease activity of UC. Results: 38 patients with UC and 12 high were included in this study. Both in high and patients with UC, MP tends to be higher in the anal side. Tear in the ascending colon was significantly lower in patients with UC than in high, 45.3 plus or minus 9.0 ohms times cm2 versus 53.5 plus or minus 9.7 ohms times cm2, p equals 0.01. The increased permeability in UC was observed also in the descending colon, only when the inflammation involved the location. A significant correlation between tear and endoscopic activity was found in the rectum only, R equals minus 0.49, p equals 0.002. There were no significant correlations between tears and UC histology. Conclusions: the MP in the colon differs according to the colonic location. The ascending colon among patients with UC showed disease-specific changes in MP. Next article is from Clinical Journal of American Society of Nephrology. Effect of intensive blood pressure control on kidney outcomes, long-term electronic health record-based post-trial follow-up of SPRINT. Background: intensive BP lowering in the systolic blood pressure intervention trial, SPRINT, produced acute decreases in kidney function and higher risk for A.I.O. We evaluated the effect of intensive BP lowering on long-term changes in kidney function using trial and outpatient electronic health record, EHR, creatinine values. Methods: SPRINT data were linked with EHR data from 49 of 102 study sites. The primary outcome was the total slope of decline in EGFR for the intervention phase and the post-trial slope of decline during the observation phase using trial and outpatient EHR values. Secondary outcomes included a greater than or equal to 30% decline in EGFR to less than 60 ml per minute per 1.73 meters 2 and a greater than or equal to 50% decline in EGFR or kidney failure among participants with baseline EGFR greater than or equal to 60 and less than 60 ml per minute per 1.73 meters 2, respectively. Results: EHR creatinine values were available for a median of 8.3 years for 3,041 participants. The total slope of decline in EGFR during the intervention phase was minus 0.67 milliliters per minute per 1.73 meters 2 per year, 95% confidence interval, c, minus 0.79 to minus 0.56, in the standard treatment group and minus 0.96 milliliters per minute per 1.73 meters 2 per year, 95% C, minus 1.08 to minus 0.85, in the intensive treatment group, p less than 0.001. The slopes were not significantly different during the observation phase, minus 1.02 milliliters per minute per 1.73 meters 2 per year, 95% C, minus 1.24 to minus 0.81, in the standard group and minus 0.85 milliliters per minute per 1.73 meters 2 per year, 95% C, minus 1.07 to minus 0.64, in the intensive group. Among participants without CKD at baseline, intensive treatment was associated with higher risk of a greater than or equal to 30% decline in EGFR during the intervention, hazard ratio, 3.27, 95% C, 2.43 to 4.40, but not during the post-intervention observation phase. In those with CKD at baseline, intensive treatment was associated with a higher hazard of EGFR decline only during the intervention phase, Hazard ratio 1.95, 95% C, 1.03 to 3.70. Conclusions. Intensive BP lowering was associated with a steeper total slope of decline in EAT4 and higher risk for kidney events during the intervention phase of the trial, but not during the post-intervention observation phase. Effects of steady glucose concentration peritoneal dialysis on ultrafiltration volume and sodium removal, a pilot crossover trial. Background. Volume overload is common in patients treated with peritoneal dialysis, PD, and is associated with poor clinical outcome. Steady concentration PD is where a continuous glucose infusion maintains the intraperitoneal glucose concentration, and as a result provides continuous ultrafiltration throughout the dwell. The primary objective of this study was to investigate the ultrafiltration rate and glucose ultrafiltration efficiency for steady concentration PD in comparison with a standard continuous ambulatory PD (CAPD) dwell, using the novel Carry-Life UF device. Methods. 8 stable patients treated with PD, 6 fast and 2 fast average transporters, were investigated 4 times. A standard 4-hour CAPD dwell with 2 liters of 2.5% dextrose solution as control and 3 5-hour steady concentration PD treatments, glucose dose 11, 14, 20 grams/H, initial fill 1.5 liters of 1.5% dextrose solution. All investigations were preceded by an overnight 2 liters 7.5% icodextrin dwell. Results. Intraperitoneal glucose concentration increased during the first 1 to 2 hours of the steady concentration PD treatments and remained stable thereafter. Ultrafiltration rates were significantly higher with steady concentration PD treatments, 124 plus or minus 49, 146 plus or minus 63, and 168 plus or minus 78 milliliter/H with 11, 14, and 20 grams/H, respectively, versus 40 plus or minus 60 milliliter/H with a controlled dwell. Sodium removal and glucose ultrafiltration efficiency, ultrafiltration volume/gram glucose uptake, were significantly higher with steady concentration PD treatments versus the controlled dwell, where the 11 gram/H glucose dose was most efficient. Conclusions. Steady concentration PD performed with a Carry-Life UF device resulted in higher ultrafiltration rates, more efficient use of glucose, increased ultrafiltration volume/gram glucose absorbed, and pulmonary rehabilitation is associated with decreased exacerbation and mortality in patients with COPD. A nationwide Korean study. Background. Poor uptake to pulmonary rehabilitation (PR) is still challenging around the world. There have been few nationwide studies investigating whether PR impacts patient outcomes in COPD. We investigated the change of annual PR implementation rate, medical costs, and COPD outcomes including exacerbation rates and mortality between 2015 and 2019. Research question. Does PR implementation improve outcomes in patients with COPD in terms of direct cost, exacerbation, and mortality? Study design and methods. Data of patients with COPD extracted from a large Korean health insurance review and assessment service database, 2015 to 2019, were analyzed to determine the trends of annual PR implementation rate and direct medical costs of PR. Comparison of COPD exacerbation rates between pre-PR and post-PR, and the time to first exacerbation and mortality rate according to PR implementation, were also assessed. Results. Among all patients with COPD in South Korea, only 1.43% received PR. However, the annual PR implementation rate gradually increased from 0.03% to 1.4% during 4 years, especially after health insurance coverage commencement. The direct medical cost was significantly higher in the PR group than the non-PR group, but the costs in these groups showed decreasing and increasing trends, respectively. Both the incidence rate and frequency of moderate to severe and severe exacerbations were lower during the post-PR period compared with the pre-PR period. The time to the first moderate to severe and severe exacerbations was longer in the PR group than the non-PR group. Finally, PR implementation was associated with a significant decrease in mortality. Interpretation. We concluded that health insurance coverage increases PR implementation rates. Moreover, PR contributes toward improving outcomes, including reducing exacerbation and mortality in patients with COPD. However, despite the well-established benefits of PR, its implementation rate remains suboptimal. Next article is from Kidney International Reports. Trajectory of GFR decline and fluctuation in albuminuria leading to end-stage kidney disease in patients with biopsy-confirmed diabetic kidney disease. Introduction. Data on longitudinal trajectory of kidney function decline and fluctuation in albuminuria leading to end-stage kidney disease, ESKD, is sparse in patients with type 2 diabetes. Methods. Using data from an observational study of patients with type 2 diabetes and biopsy-confirmed diabetic kidney disease, DKD, generalized additive mixed models, GAMS, were performed to quantify patterns of longitudinal trajectory of estimated glomerular filtration rate, EGFR, decline to ESKD associated with repeated measures of urine albumin to creatinine ratio, ACR. Results. Over a median follow-up period of 3.3 years, 155 of 319 patients progressed to ESKD. Among these patients, 91.6% exhibited a curvilinear pattern in their EGFR trajectory. The median coefficient of variation for ACR, representing the variability in ACR measurements, was 48.9, interquartile range, 36.9, 68.2. The median compound annual growth rate, CAGR, for ACR, reflecting the variation in ACR progression over time, was 43.6%, interquartile range, 0.0, 102.5, and 84.5% of patients developed nephrotic range albuminuria, with a majority remaining nephrotic and subsequently progressing to ESKD. There was a positive association between the instantaneous speed of EGFR decline and ACR. Conclusion. The observed curvilinear pattern in EGFR trajectory, high variability in ACR progression over time, and positive correlation between the speed of EGFR decline and ACR highlight the complex dynamics of disease progression and emphasize close monitoring of ACR fluctuation over time in patients with DKD. Invasively measured aortic systolic blood pressure and office systolic blood pressure and cardiovascular risk assessment in CKD. Introduction. Central aortic blood pressure, BP, could be a better risk predictor than brachial BP. This study examined whether invasively measured aortic systolic BP improved outcome prediction beyond risk prediction by conventional cuff-based office systolic BP in patients with and without chronic kidney disease, CKD. Methods. In a prospective, longitudinal cohort study, aortic and office systolic BPs were registered in patients undergoing elective coronary angiography, CAG. CKD was defined as estimated glomerular filtration rate, EGFR, less than 60 ml per minute per 1.73 square meters. Multivariable Cox models were used to determine the association with incident myocardial infarction, MI, stroke, and death. Results. Aortic and office systolic BPs were available in 39,866 patients, mean age, 64 years, 58% males, 64% with hypertension, out of which 6,605, 17%, had CKD. During a median follow-up of 7.2 years, interquartile range, 4.6 to 10.1 years, 1,367 strokes, CKD, 353, 1858 MEs, CKD, 446, and 7,551 deaths, CKD, 2,515, occurred. CKD increased the risk of stroke, MI, and death significantly. Office and aortic systolic BP were both associated with stroke in non-CKD patients, adjusted hazard ratios with 95% confidence interval per 10 mm Hg, 1.08, 1.05 to 1.12, and 1.06, 1.03 to 1.09, respectively, and with MI in patients with CKD, adjusted hazard ratios, 1.08, 1.03 to 1.13, and 1.08, 1.04 to 1.12, respectively. There was no significant difference between prediction of outcome with office or aortic systolic BP when adjusted models were compared with C statistics. Conclusion: regardless of CKD status, invasively measured central aortic systolic BP does not improve the ability to predict outcome compared with brachial office BP measurement. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.